both the fluid mechanical environment, core disease progression, but also the solid biomechanical environment and really driving disease optimization. So what I want to do about the next 10 minutes or so is really talk about my future research directions on my past training and where I want to go if I were to come to Colorado State. And really what my past research has really driven my research vision, which is really to apply mechanical engineering principles underlying biomechanics, so advance clinical diagnosis, prognosis, and treatment, but also elucidate fundamental mechanisms, fundamental mechanically induced mechanisms to kind of lead to the this development of novel therapies. And I've kind of coined this term cardiovascular pathomechanics. So I'm going to introduce 3 areas and really drive them home of the kind of underlying hypotheses, grant titles, and also specific aims, as well as funding agencies. I won't go into these into great detail, but just to give you an overview of the areas of interest. So again, the first area is in the optimization of treatment. So the data that I showed, it's on preclinical data. We really don't know how stents perform, how the relationship between biomechanics and restenosis in the clinic. So again, the hypothesis being the optimization of the stent biomechanical, we call footprint, will really reduce the failure rates. Now, the reason we haven't been able to translate this into the clinic is we don't know the complete deployed configuration of these vascular stents. Again, we're deploying these in highly nonlinear materials. These aren't opening up to the nominal diameter they would on the bench top. We really don't know what these vessels look, or what these stents look like in vivo. So really, in order to do this, you need to develop a technique to reconstruct these stents in 3 dimensions from intravascular imaging techniques. So we can't, again, excise these vessels out of these patients, perform micro-CT, which I've done in the past. You have to use what's available currently in the clinic. One of these techniques is known as optical coherence tomography. It has in-plane resolution of about 10 to 20 microns, so it can identify those key characteristics of these vascular stents. So first aim would be, in looking at the reconstruction of these stents and lesions, would be to fuse optical coherence tomography as well as micro-CT. So this is more again at the experimental level, to develop an algorithm to reconstruct that stent in 3D. And then aim 2 would be apply that in the clinic. So using clinical imaging data, can we actually understand the configuration of these stents in 3 dimensions? And if you are available to do that, the follow-up would be to apply this developed computational modeling techniques to really develop strategies to understand the induced loads on these implanted stents, and then correlate it with that with the clinical manifestation of neointimal thickening or neointimal tissue. As far as grant agencies, NIVIB and NIH, but also NHLBI, and I will say that these first 2 aims are part of a funded grant from RO3 from NIVIB. Just finishing off that first year, aim 1, and moving into aim 2, and this is a grant that I am the PI on. Now the second area is going back to kind of just overall coronary artery biomechanics. And while I've introduced, when I've discussed disease progression, the influence of fluid mechanical environment, is really what's the long-term prognostication of these vulnerable plaques by identifying the solid biomechanical environment, and understanding what is the predictive value or prospective value of wall stress in predicting patients at high risk for rupture. Aim 1 would be using that data that we've collected in the clinic on the studies that I've presented to construct models to compute that 3D biomechanical environment. Aim 2 again would be to correlate that data with known markers of disease progression. So really this is using that data set that we employed over that 6 months, but then evaluating just a solid biomechanical environment. Funding strategies, again, focusing on the NIH, and that's kind of the key driver in some of the work I do. We have an R21 we're currently writing in submission, the June submission deadline. I'm a co-PI on that proposal. Also, an extension of the area of the fluid mechanical work is trying to really broaden the applications, so not just focusing on patients with native coronary disease, but what are some other cardiovascular pathologies that you could identify with this framework. We have some preliminary data look at cardiac transplant patients. They have a form of atherosclerosis that is unique to these patient populations. So just understanding the role of hemodynamics and the progression of this disease, it's known as cardiac allograft vasculopathy. Again, developing that framework, quantifying the local progression, and then utilizing wall shear stress to really stratify these patients to optimize their treatment. Currently, I'm in some discussions with colleagues at Mount Sinai and Manhattan, submitting a K-25. We've also discussed submitting R1. Also funding sources being at the American Heart Association with the grant and aid application. Now, the last area is really more of a fundamental question, not looking at the clinical role of biomechanics and disease formation, but looking at the role of really the transport of these molecules that are involved in disease progression. So So pathology data indicates that really the key driver in atherosclerosis is the accumulation of those fatty substances under the intimal layer, so under the layer that really contacts the blood. That's a key driver in starting that disease process leading to atherosclerosis. So what's interesting is using available imaging techniques, you can actually extract the extracellular tissue microstructure by excising this tissue. So an underlying hypothesis is an exposure to disturbed flow, again that's low in oscillatory shear stress, really drives the remodeling process of these extracellular matrix proteins, and that decreases the transport of these molecules leading to an abnormal accumulation and ultimately atherosclerosis. So really understand the comprehensive evaluation of these protein alterations and really its effect on mass transport in the disease process. So again, it's just essentially also image-driven computational modeling. So identifying the microstructures from available imaging techniques, utilizing that to build mass transport models of macromolecules, and then understanding how change in the structure itself really drives that disease process. Grant agencies, American Heart Association, as well as NIH, and also at NSF, they do have a biomechanics area. I will say these first two ends recently submitted in January a scientist development grant to the American Heart Association. So lastly, I want to talk about educational role at Colorado State, particularly mechanical engineering, and just kind of my underlying engineering philosophy. It's having students achieve the higher orders of Bloom's taxonomy in the classroom. So Bloom's taxonomy is the classification to identify learning objectives for students to achieve in the classroom. And really what it's driven for, it's like allowing students to become self-directed learners. That is, as opposed to in the classroom teaching them to memorize definitions, having students take responsibility of what they're learning and understand that work outside the classroom, and using the classroom itself to really, as a medium, to achieve those higher orders of Bloom's taxonomy. And a lot of this has come through the problem-based learning course that I've been involved in at Georgia Tech, which is very similar to the BME 300 here at Colorado State. But it's really teaching engineering problem-solving skills, teaching students to understand how to think like an engineer, so that regardless of the problem that you give them, whether it's at the research level, at industry, that they have the correct tools to really drive that problem-solving process. As far as my educational, how I can help the department, obviously in the area of mechanics, whether it's computational mechanics or understanding theoretical mechanics, as well as biomechanics, so kind of any area of biomechanics or just kind of traditional mechanics is being just taught in the curriculum. And I will say that while all my degrees are in biomedical engineering, I've really received training as a mechanical engineer. So my PhD advisor was a mechanical engineer, my postdoc advisor was an aeronautic engineer. So I really kind of more familiarized myself with mechanical engineers. And while I look at blood flow, I think of these vessels, again, it's just straight tubes. So applying the Navier-Stokes equations, whether you're looking at a lead pipe or a blood vessel, it's all the same. And this are, I've been involved in teaching fluid mechanics at the undergraduate level at Georgia Tech. Looking at current courses in the department where I can potentially serve as an instructor, of course all the areas focused on mechanics itself. So heat and mass transfer, I have a large area of expertise in computational mechanics, so both finite element analysis as well as fluid mechanics. Both advanced fluid mechanics at the graduate level as well as biofluid mechanics. And I have taught this course at Georgia Tech for a semester several summers ago. And I'm not just throwing up figures that I pulled from the web, these are actually figures taken from class notes. So again, I have been involved in lecturing at the bioengineering level. But again, we're looking at 1D transport across the membrane, finite element analysis, boundary layer theory, really key, key principles in mechanical engineering curriculum. As far as potential courses to develop, obviously at the undergraduate level, potentially biospholic mechanics, also at kind of advanced cardiovascular mechanics. So again, those underlying continuum mechanics principles, tensor calculus, applying those to the cardiovascular system, both at the fluid and solid levels. And also some potentially computational methods in biomechanics. I know there are faculty that are interested in biomechanics and do some modeling. So whether this is a finite element method or computational fluid dynamics or a combination of both, I think this is courses that would be available to teach if there was a significant amount of interest. So with that, I'd like to acknowledge several people, both at Georgia Tech, headed up by Don Giddens, Jimmy Moore, was at A&M, now at Imperial College, and then John Oshinsky at Beam University. As for regarding funding sources, the first part of the work was funded through the American Heart Association postdoc grant. Again, I have ongoing funding from the NIH, and we do have some other collaborative grants with industry colleagues, both Volcano, some imaging companies as well as pharmaceutical companies. And with that, again, I thank you for your time, and I'll be happy to answer any questions. Yes.
Thank you for the talk. It was very diverse, so I really enjoyed that. I was wondering about your stent finite element analysis. So it looked like when you reduced your footprint, as you stated it, you kind of experienced higher stress gradients. I was wondering if that's kind of a clinical issue, having those significant gradients between the struts. And then kind of as a follow-up, if you looked at all about, instead of changing the structure of the stent, just the material properties of the stent, maybe reducing stiffness.
Right, so I'll go to your second question first. That one's easier to answer. So if we were, for example, to change the material, again, with those two designs, the design that we identify as a high stress stent would still be identified as a higher stress stent. Primarily, it just has more material there. So regardless of what material it's made out of, that's going to induce high stress in the wall itself. Regarding looking at gradients, so we did not specifically look at gradients in that study. That's a very good observation. So there are studies at the cellular level that indicate that cells do adapt to that to shear grade or stress gradients, and potentially may lead to more new intimal tissue growth, cellular infiltration, and so forth. So that is something we have thought about, but I will say at the in vivo level, even those higher gradients, we still saw less new intimal tissue growth with that lower stress stent than the high stress stent.
Thanks.
Yes.
Are these stones usually stainless, or are the nitrile ones what you're doing apply still well there?
Yeah, and again, it goes back to the material. It really wouldn't matter what the material. It's again, all of that is would be covered by the design. That being said, they primarily are stainless steel. There are also cobalt chromium ones, also some nitrile stents. What we didn't look at and what's really kind of moved into the interventional area is coating these metallic structures with drugs that essentially, they're called drug-eluting stents. These drugs over time elute to really reduce that new intimal tissue proliferation. That being said, failure rates are still in the order of anywhere between 5 and 10%, and there are known failure rates of drug-eluting stents that you don't see with a metallic stents. What's ongoing clinical trials in the States are actually stents made out of bioabsorbable materials. So these stents have over 2 to 4 years completely are reabsorbed into the body. So the benefit of that is these patients now don't have a chunk of metal in their heart that prevents them from getting, for example, an MR, significant amount of artifact with CT. That being said, there are some limitations there. However, the biomechanical framework that we've designed can really be utilized to evaluate any material or any stent design itself. So I think that the work that we did, even though we looked at stainless steel, I think it applies to all stents.
Right.
And of course, we're trying to influence those in the market to pay attention to that.
And I may have missed this, but you talked about how the commercial stents on the market are just widely varied recent dosage rates, value was low. So did your predictions of high stress and low stress kind of correlate with that?
Right. So there have been studies very similar to ours, just not at not in the preclinical levels. They didn't have histology, but those stents that induce higher stresses have higher failure rates in the clinic. Yeah. So there is that known association.
Right.
So, yeah. Yes.
Can you comment a little bit on the software you're using for fluids and solids?
Yes. We all use commercial software from the fluid standpoint. We use Fluent. From the solid standpoint, this work was done with the MSC package, so Mark the solver, Patrons, the GUI. I've also been using Abacus for some things as well. Yeah, these are all commercial softwares.
So it was a very nice talk.
Thank you.
So you just mentioned about the drug-eluting stents, and I think one of the issues they have is like thrombosis that can happen. So, have you worked on looking at how that affects the wall shear stress? Sort of, would that govern the design betters for drug-eluting? You said some of the, so I'm sort of talking about both things that about sort of combining.
Yeah, so the stem work I did was all the solid biomechanics, some work that also came out of Jimmy's lab and looked at the fluid mechanics, and it showed that was design dependent, and that stents that have higher late thrombosis rates are areas where you have greater low and oscillatory shear. So again, it's trying to optimize the design so you reduce the amount of areas that have kind of low and oscillatory shear in the fluid environment, but also that you reduce the wall stress. There's kind of this counterplay between those two design components. ultimately, an area that I actively want to move into is the whole idea of fluid-solid interaction, where you can model both the fluid and solid domains simultaneously. And again, we have the framework kind of to do them each independently, but it's kind of combine them together, which there are some limitations from the software package currently that hopefully we can overcome.
So it was a really nice talk, and I was fascinated by the earlier clinical one about the plaques and the more necrotic tissue with the 6-month follow-up. And I'm probably reading too much into this, but do you think that, like, you know, the statin treatment, while it shrinks it overall, it makes it more necrotic, or is like making them more prone to these plaques that break off by giving them?
Yeah. So I would say no. I mean, so there's the studies looking at the effects of statins. You're talking like 40,000 patients studied.
Right.
But the way they look at changes in plaque is at the volume level. So they can identify with ultrasound how much the plaque changes over the volume. So they don't really look at the focal changes, which is something, we have a study going on looking at the focal changes. So that may be true, but I'm not sure I really want to say that now. That really, I think,
Well, like you said, overall, the big study shows
yeah,
that.
and again, it's the long-term studies that have shown if you take statins, your mortality rates.
Right.
increase.
But if there could be that individual aspect, right, for certain
Right.
individuals, it's not the right.
It's kind of moving to that personalized medicine because, you know, while statins work, they don't work on everybody. And
Right.
so, you know, identifying those patients that may benefit from statin therapy, maybe may not. You know, I think that's this kind of a framework to evaluate the imaging data allows us to understand that.
Thanks, yeah, Lucas, it was a great talk. Outside of my area of expertise, but definitely interesting. And I think there's a lot of relationships between what you study in fluid mechanics and what happens in solid mechanics, as we know. And so I was just asking Ben, my grad student, because he knows this better than I do, and I asked him about it. Is there the capability to incorporate like a damage component into your constitutive model? Either to the biological tissue or to the stent, which I'm assuming the
Yeah.
properties change with time.
Right. So there are damage models. Alexander Rochef is the name that comes to mind that's looked at the effect of increased stress and cellular kind of growth. So and we
Yeah.
could incorporate that into the model. Again, as kind of a question asked earlier, that we use computational codes. However, that allows us to use kind of subroutines where we can feed in new material models. Again, our focus on the stent work really wasn't focused on the material model of the vessel itself, because again, you know, it wouldn't really change the results we had. It would just adjust the level of the stresses induced. So that is something we can, you know, easily adapt our model to and really look at how damage drives the disease process. I think that damage really comes into play when we stented computationally healthy vessels. So in that work, we didn't show disease components. We have added in plaques before, and that's where you really drive up the stresses, and obviously that's going to lead to plaque fracture and things like that. So really you can advance those modeling techniques by including, for example, damage.
Hi, I'm intrigued by your thoughts on studying plaque formation behind the initial formation. Because, like, wow, I mean, there's a lot of physiological models about what is happening. But do you have any thoughts yet that you can share? Because maybe you haven't filed your stuff yet on that. About how you would actually look at that.
Yeah, so there are imaging techniques where you can extract the wall proteins. One that comes to, that I've used is multiphoton. So this doesn't, you don't have to stain the tissue. You can actually just take the tissue out fresh and create these thin optical sections. Multiphoton technique, it's very similar to confocal, but it basically removes stack scatter. So you really get high resolution imaging data of elastin and collagen, which are the key components of the wall itself. So from that, you can extract various morphological data. All of these proteins have pores. For example, elastin forms these sheets and have these pores, and actually those pores are key drivers in what material moves through the vessel and what material gets trapped. What hasn't been understood is how those pores change, or how that morphology changes across the disease time course. So my area is investigating the morphological change of the structure across the disease time course, but more so as really to use that imaging data to construct mass transport models to understand is how much is that permeability decreased, what are the permeability coefficients, and is really altered mass transport, does that actually precede disease progression? So really does those morphological changes, that reduction in transport properties actually precede at subendothelial accumulation. So again, if that's the case, well then can we start looking at mechanisms that cause that remodeling and actually use them to prevent abnormal accumulation?
Cool.
So along those lines, how thick is the typical endothelium? Are you imaging 3D endothelium to see that?
Yeah, in the endothelium, you're talking cells, you know, they were, I think 40 to 50 microns, yeah, very small. So with the imaging capabilities, I mean, you can image on the order of 300-400 microns, so you can actually image through the subendothelial layer into the medial layer itself. The work we did was at intervals of about half a micron, so you really get these high-res spatial images.
And you're just looking at column, whereas this is elastin and second harmonic column.
Yeah, two photon for elastin and second harmonic.
Anybody else? All right, Melissa